Confounding by unmeasured covariates can destroy observational studies. In this series of talks, I'll lead you through study designs that can keep unmeasured covariates from becoming unmeasured confounders. In this first presentation, I'll give an extended example of unmeasured confounding, and I'll look at the one study design that's guaranteed to be free from it, the randomized trial. In general, confounding arises when a characteristic marked C here gives rise to both a treatment and to a disease. In that case, there appears to be a correlation between the treatment and the disease, which has nothing to do with any causal effect of treatment, but simply the joint effect of the confounder on both. We have a variety of methods for controlling for or blocking the effects of confounders. Facing in this series of talks is that of unmeasured confounders. With these, since we haven't measured them, or we may not even know that they exist, there is no possibility of control. The methods that have been developed to deal with unmeasured confounding are best classified in the context of this causal diagram. So we have an unmeasured confounder that gives rise to both treatment and disease. With randomization, the connection between all confounders and treatment is blocked by the physical act of randomization. With self-matching, we compare different times of the same person's experience to compare treated and untreated periods, and by the matching, any relationship between characteristics of the person and confounding. We can use proxy variables as stand-ins to control for the unmeasured confounder, either in its effect on treatment or in its effect on disease. Similarly, we can look at intermediate variables, which sometimes are proxies, as stand-ins for the unmeasured confounder, either as it predicts treatment or as it predicts disease. Finally, we can use instrumental variables, which the relationship between confounders and treatment. So we look at a pure unconfounded determinants of treatment in their relation to disease. In a table, here are the methods we'll talk about, and here are the places where they break confounding caused by unmeasured covariates. As a motivating example, we'll look at the relationship between cimetidine and gastric cancer. Cimetidine is a potent drug for acid suppression in the stomach, which has been used for the treatment of gastric ulcer, other kinds of peptic ulcer, and for the diseases related to gastric hyperacidity. In the 1980s, when cimetidine was first introduced, it became widely used, and shortly after introduction, there were case reports of the occurrence of gastric cancer in people who had used cimetidine for a few months. A group led by David Colin Jones had created a surveillance program looking at cimetidine users in general practices in the United Kingdom. He and his colleagues took people who had received a cimetidine prescription in a surveillance year and then followed them forward for 12 months from the time of that first prescription. To each user of cimetidine, they matched a comparison person from the same general practice, the comparison person having the same age and sex as the cimetidine user, but who was seen for a different condition. They used the data that they had been collecting to examine the incidence of stomach cancer. Here is what they found. The area marked study period marks off the 12 months beginning with the first dispensing of cimetidine during the year in which they did their surveillance. Individuals could have had cimetidine beforehand. Black bars, the short ones, record the incidence of new cases of gastric cancer during the study period, as well as before and after. We see there was a case in the first 3 months and so on as you move across. The other bars give the number of cases of stomach cancer that occurred in cimetidine users. And you can see that these are in huge excess by comparison to the control group. The excess is biggest in the first 3 months, but continues for a long time thereafter. Colin Jones and his co-authors suggested that the stomach cancer incidence was only an artifact of the treatment having come before diagnosis in a disease that was already present. That is, people they hypothesized had problems of digestion or dyspepsia that led them to be treated with cimetidine, and those problems really were due to the stomach cancer. They hypothesized that that effect would disappear with longer follow-up. Here's a follow-on study that they did. Instead of looking at the occurrence of stomach cancer in a control group, they used the expected numbers of cancer deaths, and deaths from all causes, in the population of England and Wales at that same time. We see the deaths from malignant neoplasm of the stomach cancer, were high in the first year and did indeed fall off toward the expected count over 4 years. But unexpectedly, deaths from lung cancer, high in the first year, stayed high over 4 years of follow-up. And deaths from diseases of the gastrointestinal system also started high and stayed high through follow-up. With these data, Colin Jones and his colleagues put together a set of hypotheses to explain what they had found. They maintained still that the occurrence of stomach cancer was due to the same bias they had identified originally, noting only that it took a longer time for the bias to play itself out. They suggested that lung cancer was occurring because there were shared determinants of the lung cancer cases and the use of cimetidine, the cimetidine users having an excess of smokers. For the gastrointestinal disease, they simply suggested that in general conditions that might motivate cimetidine use might lead to death eventually and be identified as such. Under each of these hypotheses, they suggested that there were unmeasured factors that led to cimetidine use and also caused the outcomes. They argued that cimetidine did not cause the deaths from the stomach cancer, the lung cancer, or the GI disease, but that these associations were created entirely by confounding. But were they correct? They couldn't know on the basis of the data that they had. However, had Colin Jones and others used different study designs, they might have been able to address these ideas directly. The design that's at the core of clinical research is the randomized controlled clinical trial. Randomization is a method for allocating treatment to individuals in such a way that you have an expectation that there will be no correlation whatsoever between the treatments given and any predictors of outcome. Randomization creates balance between all the characteristics other than treatment between the treated groups. This balance occurs in statistical expectation. That means the approximation of balance gets better and better the more subjects are entered into the study. As a result of balance, unadjusted estimates, simple comparisons between the two treatment groups, are unbiased estimates of treatment effect. That is, they reflect directly the effects of being in one treatment group versus the other. And it doesn't really matter what kind of outcome measure you want to look at. All of these work in under the guarantee of no unmeasured confounding, which look at an example. This is a study of dutasteride on the risk of prostate cancer. Dutasteride is one of a class of drugs that shrinks the prostate. And there was reason, even prior to this study, to think that the same mechanisms that led to shrinkage of the male prostate might reduce the risk of cancer. The randomized trial had over 4,000 dutasteride patients and a similar number of placebo patients. Because of the randomization, all the factors that were measured in the patients were very similar to one another. We have good reason to believe that there was balance on unmeasured factors as well. As expected, the dutasteride patients had many fewer outcomes that were related to enlarged prostates. Excitingly, the incidence was also about 20% lower in the treated patients than in the untreated patients. The randomization guaranteed that this difference was not due to any difference in the baseline characteristics of treated patients. That is, there are no unmeasured confounders that could account for these associations. So we can treat them as consequences of dutasteride therapy. In summary, let's consider the problem and one resolution. Anything, any characteristic that leads to both treatment choice of one treatment over another and to an outcome is a confounding factor. Confounders distort estimates of treatment effect. In observational studies, there are many ways of blocking the effect of confounders as long as the confounders are perfectly known. When the confounders are unmeasured or unknown, conventional methods for control don't apply because they require knowledge of the factors in order to enter into a statistical model or to whatever design technique we've chosen. However, proper study design can break the association between unmeasured confounders and either treatment or outcome. The first of these is the randomization of treatment assignment to individuals, which mechanically breaks the association between confounder and treatment. In the next talks, we'll look at other techniques. Thank you for your attention.